So brilliant. Thank you, everyone. Welcome to this social prescribing information session. And what I'm going to do is just start to share my screen and then we can get started. Hopefully you will see the full screen presentation. There we go. Right, so for those of you who I haven't met before, my name's Sarah Marrison. I'm Vaughan's Social Prescribing Engagement Manager, but I'm also in the sort of role of regional lead for the NASP Thriving Communities Network, and that covers Northeast, North Cumbria and Yorkshire. NASP is the National Academy for Social Prescribing, and so it's a national body, and we have a contract to deliver the regional support for that, for the programme, the NASP programme. So the aims of this session today, it's very much an introductory session. So if any of you have been to any of these sessions before, I should say now it has been the same kind of session that we've been delivering each month, and then it's only been that the only difference has been that obviously the audience asks different questions, etc. So so basically it's about gaining knowledge and understanding of social prescribing itself, but also gaining some insight into what the social prescribing landscape looks like in the Northeast, North Cumbria and Yorkshire. Increasing your awareness of the changes to the health and care system and how that precipitates change within the voluntary sector as well. It should also clarify some key terminology for you, which might help you understand the system a little bit better and be able to interact with it better, and potentially help you identify what next steps you might want to take. So I put, feel free to note down any questions to ask after the presentation, or indeed, if you think of something and you want to pop it into the chat, we can pick up. But no question is a silly question. Please, you know, people come at this from all different angles, all different levels of knowledge, from the voluntary sector, from the health perspective. And, you know, quite honestly, it's just a good chance to kind of ask anything that's been, you know, on your mind, and I'll try as best I can to answer that question. Hopefully, I should say, hopefully it'll be about half an hour of me talking, so I apologise if that's a little bit dry, but then we should get time for questions. But I'll just crack on. And first of all, I just wanted to talk a little bit in terms of setting the context about what personalised care is. So NHS England produced a long-term plan a number of years ago, and within that, there is a target of providing personalised care to 2.5 million people by 2024. And personalised care is has a number of different elements to it, and one of those elements is social prescribing, and it's just one part of a whole system that is meant to tackle health inequalities. So if you want to find out more about the term health inequalities and what that means, then on this slide there is a blue link at the bottom, which is to a King's Fund video and King's Fund webpage, I should say, which obviously has lots of useful information to simplify exactly what we mean when we're talking about health inequalities. So that could be a useful link for you if you're quite new to this sort of area of work. In terms of personalised care roles, there are 3 roles which have been developed. So these are 3 different jobs, and we call these the kind of the personalised care roles, and they often work as part of a team. Some of them you'll have heard of: social prescribing link workers. Sometimes they're called other things. They don't always get called link workers. Some might be called community connectors. Some might be called yeah, sorry, I can't remember. There's probably 2 or 3 different roles, or 2 or 3 different names that they could be called. They work really closely with colleagues who are health and wellbeing coaches and care coordinators, and as a team, they bring people in through the referrals, the social prescribing referrals, and they kind of work on different elements of supporting that person. So I'll come on to that in a bit more later, but the main one that we connect with and we work with through the programme that we run are the link workers. And there are a number of link workers roles being developed which are a lot more specialist. So some of them may specialise in children and young people, or financial support, veterans, mental health. It varies, but there are also a lot of link workers who have that more kind of generic work role and might work with people of all ages and all backgrounds. In terms of social prescribing itself, it's generally, the definition is generally this one on here. So it's where a link worker works with a client or a patient, usually who's been identified by a GP, perhaps. And it's about them working with them to understand what their personal background is, their circumstances, and where they are with their health and well-being issues. And then they work with them over a period of time to determine what matters to them, and then use that sort of knowledge and that insight to help refer that person on and introduce them to local activities, which will help them to improve their own health and well-being and be better able to manage any pre-existing conditions that they have. But also it's a preventative thing as well. It can prevent deterioration of particular conditions. So is often used for things like loneliness and isolation, and kind of more low-level mental health issues. In terms of background, the idea of referring people to support activities is not new. It's been happening for many years. The voluntary sector has always been pretty good at this. You know, we kind of tend to be well networked into other organisations in our sector, and we're able to refer people to activities to support health and well-being. But it's more recently that the NHS has realised the potential of social prescribing, to look at sort of reducing that medical model, to stop, you know, to refer people, so that, you know, the NHS is really good at kind of fixing emergencies and things that go wrong and physical kind of ailments and things, but it recognises the value of the voluntary sector to kind of bring in that non-clinical intervention that can support that person and ensure that they have more social interactions, more support, more feelings of purpose, and that all in it helps improve patient outcomes. The difference now is, and the reason why we hear so much about it, is that the NHS has invested a lot of financial support in terms of getting social prescribing link workers in GP surgeries, in primary care networks around the country. And I'll go into a little more detail about some of the terminology, such as primary care networks, shortly. So hopefully I'm not going to bamboozle you. This is just a very short video, which is useful because it will help set the context of what is currently changing and why, and how that should hopefully help the health system work better to support its community. So I'm just going to press play, and then I'll come back to you when that finishes.
Big changes are taking place across the health and care system. What does this mean for the organisations that make up the NHS? How will they collaborate with other parts of the system? And what will these changes mean for you and me? When the NHS was set up, it focused on treating single conditions or illnesses. Since then, our health and care needs have changed. More of us are living longer, and many have multiple conditions that require regular, ongoing care. However, this hasn't been reflected in the NHS's structure, a patchwork of organisations that often work independently from one another. Navigating this can be confusing and can have a negative impact on our experience of care. So, for some years now, health and care staff and leaders have been working to bring organisations closer together to better meet our needs by working in a joined-up way. Primary and secondary care, social care, mental health and community health services have been seeking to partner with each other in different ways. At a very local level, GP surgeries have been coming together to form primary care networks, groups of practices working together across areas called neighbourhoods. By sharing resources and working closely together with other local people and services, they can provide a wider range of services than a single GP surgery. Health and care organisations have also been working together across larger areas called places, often covering the same area as a local authority, where large parts of the NHS budget are spent. Here, local government, charities, residents and NHS partners can work together to understand and meet local health needs. But previous laws have prevented services becoming even more joined up. The 2022 Health and Care Act aims to change this and make it easier for organisations to work together. But what do these changes look like? Organisations are now coming together across even larger areas to form integrated care systems, partnerships of health and care organisations that plan and pay for health and care services. There are around 40 integrated care systems across England, and although they've existed for some time, the Health and Care Act gives them legal status, as well as new powers and responsibilities. Integrated care systems are made up of two parts: integrated care boards and integrated care partnerships. Integrated care boards decide how the NHS budget for their area is spent and develop a plan to improve people's health, deliver higher quality care and better value for money. Integrated care partnerships bring the NHS together with other key partners, like local authorities, to develop a strategy to enable the integrated care system to improve health and well-being in its area. NHS trusts are also coming together to form provider collaboratives, new partnerships that can bring together providers such as hospitals, mental health services, and community services. So how are these new structures funded? Integrated care systems get most of their money from NHS England, which is the national body for the NHS in England, and sets the operational priorities for the health system. It's responsible for the health services you and I access day to day, which are inspected and regulated by the Independent Care Quality Commission. The Department of Health and Social Care sets out what the NHS is expected to deliver for the money it gets from the government, which comes from our taxes. It also holds budgets for some of the other areas that have an impact on our well-being, like public health. Throughout these new structures, local authorities play a key role. They receive money locally and from national government, which goes towards funding a range of services that support our well-being and prevent ill health. So, what does this all mean in practice? The Health and Care Act has put in place a legal framework that enables services to work more closely together, so it's easier for you and I to receive the care we need, when and where we need it. For these changes to succeed, staff and local leaders will have to work with one another differently, alongside key partners in local government, the voluntary sector, and communities themselves. Of course, services face other challenges like workforce shortages, growing waiting lists, and the impact of the COVID-19 pandemic. While the new structures won't fix all these issues, by enabling services to work more closely together and join up services for patients, it's hoped that the health and care system will be better able to meet our changing health and care needs in the future. Find out more about how the health and care system is changing at www.kingsfund.org.uk/explain.
Right, hopefully you found that useful and enlightening. It's one of a number of really useful kind of animations and things that you'll find online. YouTube has some great stuff on there, particularly from the NHS. Also, there's a lot there from King's Fund. But I just wanted to say that as we move on, we'll talk a bit more about integrated care systems and how that has a potential for providing opportunities for commissioning of social prescribing services moving forward in the presentation. But if you want to find out more in the meantime, there's information on the Vaughan Health and Wellbeing Hub, which is on our website. Again, the link is there in blue. I appreciate you can't click on it now, but when I send the slides out after the event, you'll be able to click on it and find the link to that, and just read a bit more about the work that we're doing as an organisation to connect the voluntary sector into the integrated care system, and also more about the work we're doing around social prescribing. So I'm going to start a few slides here which start to clarify what we mean by some of the terminology you'll hear around social prescribing. And the first one is about the social prescribing pathway. So a lot of the time in NHS and in healthcare services, they'll talk about pathways, basically, which is often referring to the route of care and treatment. So this is what we mean by the social prescribing pathway. So it's the kind of three-step process, really, where you have that sort of referral from a health or a social care, you know, a health clinician or a social care member of staff. That link will go to a social prescribing link worker, who will then work with that person and have that conversation about what matters to them. So it's the personalised care approach. And from that discussion and that relationship that's built up, they will then recommend or facilitate or support that person to access an activity, a support group, or a particular service, which is often delivered by the voluntary sector. Not always, but in most cases it is. And below that sort of arrow that sort of shows the pathway, there's also an arrow there that shows the investment and the capacity. And the issue we have as a sector, as a voluntary sector, is that the NHS has invested heavily in social prescribing link workers across the country. But what it hasn't done is it hasn't invested money in the voluntary sector, who are the ones who are delivering that. So in effect, they're providing the services. And one of my colleagues, Jane Hartley, often equates and uses the idea of kind of travel agents and holidays. So obviously the NHS has invested in lots and lots of travel agents, but if there are no holidays, if there's no voluntary sector, or if the voluntary sector doesn't have the capacity to take those referrals, then there's no point having lots of travel agents if you haven't got any holidays to refer people onto. So we'll just move on. And this NHS diagram shows really clearly how there are a number of different elements to good social prescribing. And most of those are some of the things we've mentioned so far. So, you know, the person-centered approach, making those connections to the community networks and the third sector. So knowing what's going on within your community. The aspects on the other side, on the left, is more about making sure that referring professionals really understand social prescribing, understand the benefits of it, and the research and the evidence around it, and also recognizing that most link workers, if they're working well within that community, they should have an element of community building or community capacity building, in order that they can perhaps, because they may be able to identify needs that aren't currently being addressed within that community. So, for example, if they identify that a person could really benefit from a befriending service, but there isn't currently a befriending service operating in that area, then, you know, there should be an element of them being willing to reach out to organisations and to support them to see if there's some way that they can create an activity or start a group to service that kind of particular need within the community. But I think the most important element is the one at the centre, the bottom of the diagram, which is about the transfer of resources from the statutory sector to the third sector. So really, for social prescribing to work properly, there has to be some money exchanges hands, there has to be some transfer of resources, and that is often the sticking point. And we are getting to the point where things are moving forward, but just at the moment, that's that's still a little bit of an issue, and often it kind of confuses voluntary groups a bit, where they can't quite see how that sort of resource might come to them. So we'll talk a little bit more about that shortly. I'm going to address a few more terms and things just to make sure we all are on the same page. So we're talking, you'll hear about host organisations. So just to clarify, a host organisation is any organisation that employs social prescribing link worker posts. They may also host some of those other posts that we mentioned, the health and wellbeing workers and the the care coordinators. And they, as I say, they may work as a team, but they may be employed by an individual GB practice, but more commonly it would be a primary care network, so that cluster of GP practices that work together and share resources. So they would often employ a number of link workers who would work across all of the surgeries within that primary care network. We have a number of voluntary sector organisations across our region who also host link workers, and they will often have a contract to deliver that link worker support and function over a particular local authority area or even a whole county. We also have a few examples of other organisations such as colleges or schools employing link workers, specifically where they're wanting to support children and young people. But it's mainly primary care networks and voluntary sector organisations who host link workers. And as I say, that's a very wide-ranging picture across the region. But the good news is that if you're a voluntary sector organisation and you're wanting to connect into your local link workers host organisations just to raise awareness of who you are and what you do, then you can contact us. My email address is going to be on at the end of the presentation, because we can help you connect in with them and just to develop that kind of closer working relationship. On the flip side of that, we have host organisations. We also have provider organisations. And as you would hopefully expect, any organisation that runs any of the activities, so community-based services and activities, is often referred to as the provider organisation because they're providing the services. And many of them will accept kind of referrals. They will accept people self-referring. They will perhaps have referrals from other voluntary sector organisations or from link workers, GPs, etc. But the interesting thing is that because there's still a lack of understanding, I think, as to how social prescribing works, so they won't always be branding themselves or advertising themselves as a social prescribing service. They may just be an organisation that's been around for years and they provide certain sessions that people can come and join, and link workers have found out about it and who have suggested that patients go there. And it also doesn't mean because they're a provider of services that they're receiving any direct funding from the NHS or from health systems. Many won't be. There may be some who have had contracts with clinical commissioning groups previously, but many will probably just be funding the activities through grant applications, charitable foundations and trusts, or other fundraising that they do. So, it's not a clear picture and it's not all funded through health funding. But again, the good news is that if you're coming to us from the host organisation side and you're here sort of in your role as a social prescribing link worker and you want to find out more about who's available in your area and what sort of activities are available, then we're more than happy to do the same for you to try and help match you up and connect you up with local services, and so that might be also through kind of connecting you with some of our partners. How referrals happen is quite straightforward, but I'm just going to mention three types. The first type is reactive referrals. So this is the vast majority of referrals. So that is where a patient will see a GP or another clinical member of staff, and they will tell them that they're not feeling great, that they have some issues that they want to address, and the GP will then react to that by suggesting that they go and see one of the social prescribing link workers within the PCN or within the practice. And the link worker will then find out what matters to the patient, and they will use their local connections to help them to connect into a local activity that can help improve that health and well-being and potentially help them support manage how they're feeling. They may decide that they want to do a supported visit. They may be able to help that person kind of embed themselves in that new activity, but it really just depends on their capacity, really. And all host organisations will have different paperwork and different referral systems. So that's a reaction. That's a reaction to the patient saying, I'm not feeling great. Proactive referrals are where GPs or primary care networks will actually identify a particular cohort of patients that they want to get in touch with. So it might be those who have a particular long-term condition, or it might be those who've had multiple unplanned hospital admissions in the last year. So they'll actually then proactively kind of look through their patient lists, and they will contact patients who fit those criteria and then have conversations with them about their health and well-being and what matters to them, and how social prescribing could help them manage their condition and sort of improve their health and well-being. So this is more about the clinicians identifying cohorts that are perhaps high intensity users, or those who are potentially costing a lot of money in the NHS because of those unplanned admissions or A&E attendances, etc. So the proactive approach is about the clinicians figuring out who they can get in touch with and how they can help reduce that sort of workload for the NHS, really. The third one is something that I mentioned earlier, which is self-referrals. So you know, lots of organisations, lots of provider organisations are just happy to, you know, they advertise their services quite widely, so people can literally self-refer and attend. They don't need to go through the formal process of seeing a link worker. Or some GPs will often advertise their social prescribing link worker service through social media, on their website, on notice boards, so that you don't have to necessarily go and see a GP or a practice nurse. You can actually go straight to the link worker yourself if you feel that you would benefit from some sort of social prescribing service. So that's an important one, and I think that's something that, for example, my GP services do that quite a lot, and their social media, they use their social media a lot to put the word out about that. In terms of the types of social prescribing activity and provision that's out there, there's a huge range. And within the work that we do, the Thriving Communities programme that we deliver on behalf of the National Academy for Social Prescribing, we have a number of national partners who are sort of reflective of the varying types of social prescribing that are out there. So you may have heard of a green and blue social prescribing, which is nature-based activities or activities based on or near water. So we work closely with Natural England. There's obviously lots of opportunities for arts and culture activities, and Arts Council England is our partner. Excuse me. Arts Council England is our national partner. Heritage activities, we've got Historic England. Physical activity, we work closely with Sport England, and we have a number of these partners have people around the country who work within the regions as well as a national rep. And we also have, for the financial support aspect, we have a partnership with the Money and Pension Service, and financial support is one of the areas that's been, you know, there's been a huge increase in the number of people needing support because of the cost of living crisis, because of the impact of COVID and the kind of the exacerbation of the health inequalities and the poverty side of things over the last few years. That's been a really important part of the work of both the partners and the social prescribers in the area. And as I said, we have some of those partners, we have regional leads that we can work with quite closely. I'm just coming on to the section around how social prescribing is currently funded, and the main issue we have at the moment is that it would be logical, for example, to say that each patient has a set amount of money associated, and as they get prescribed an activity, that funding would flow down. But at the moment that doesn't happen, so there isn't funding that travels with the patient to pay for their support activities. But substantial investment has been made by the NHS at the workforce end of the pathway, so that is making sure that there are lots and lots of link workers and health and wellbeing coaches and care coordinators in order to support people. but it's that lack of investment in the provider end, the activities, that has been a real barrier up until now. And I would say that currently the system is still reliant on those provider organisations having already be running those activities or having secured funding from other sources, like those I mentioned earlier on, donations, crowdfunding, grants, or even earned income if they have a building, a community building that they can kind of rent out part of, or cafes or whatever. So it does mean that at the moment there is a lot of pressure on the voluntary sector in that provider role because of the increased demand, and there's just the financial pressures that everybody is under at the moment. But there is light at the end of the tunnel, and that is because of the integrated care system. So as the King's Fund video highlighted, it's about bringing people together and recognising the voluntary sector as an equal partner in the system, and that in lots of instances the medical model isn't needed. It's that kind of community and wraparound support and care that can help a lot of people that don't necessarily need medical interventions and don't need medications. So it's about the recognition of local knowledge, because as the voluntary sector, we have access into those communities, we have their trust, we have lots of people with lived experience in a variety of different sort of capacities and backgrounds, and the voluntary sector is really good at demonstrating sort of tangible results about how they already improve people's health and well-being. And as we're moving towards the ICS was only formally became a legal entity in July last year. The first few steps were all around governance, about getting the integrated care board set up, and then the integrated care partnership, and making sure that that is really representative and getting elected members to represent the voluntary sector on it. And the integrated care system has now been developing its initial strategy, and following on from that should start to be the more detailed discussions about looking at the health inequalities within the Northeast and North Cumbria region. I realise that some of you are probably from other parts of the region, so I will come on to that in a minute about how that's happening in other places. But for example, in the Northeast and North Cumbria, that will be, we'll then start to have those opportunities to talk about what the voluntary sector can offer to come together and to be more organised in terms of how we can collaborate to offer services that will address particular health inequalities and health needs within our region. So there's going to be a lot more emphasis on collaboration, and it's really important that the voluntary sector is fully represented and advocated for. And so I want to mention something that we deliver at VON called the VCSE Partnership Programme. And it does have an equivalent programme in both South Yorkshire, West Yorkshire and Humber and North Yorkshire, which I will mention and I'll give the contacts for later, just in case you're coming from that sort of the Yorkshire part of our Thriving Communities region. So that is a programme that basically provides opportunities for the ICS to come directly to the voluntary sector to find out what it can do to and to potentially commission work in the future. But also a way for the voluntary sector to actually feed up issues into the ICS and to get those looked at and addressed, which is really positive. So at the moment, what I would say I find the challenges is that there's a number of challenges for provider organisations, so those who are delivering the services, and really the main one is just getting to grips with this new health and care system. Resources and funding for activities are difficult. As we've said, they're still reliant on short-term grant funding, and there has been slow progress on commissioning. But given where we are now with the integrated care system, I feel like that's going to start to progress quite quickly from this point onwards. As we probably all know who've worked in the voluntary sector, recruitment and retention of good staff and volunteers is quite difficult when you have lots of short-term funding, so that can cause a problem. Some of the providers are finding that they need to be quite clear about what levels of need they can cope with as an organisation and within that service, because obviously we need to make sure and communicate with link workers to make sure that they are sending the right the right sort of people to the right sorts of interventions. So, you know, there are interventions around that will support people with those kind of higher levels of need, you know, people with defined needs like, you know, learning difficulties and autism, and or, you know, particular mental health conditions, the more serious mental health conditions. But there's also lots of opportunities for those who have lower level needs, but it's just about being clear as to what each organisation is able to deal with, and making sure that that training is in place for those staff and volunteers to feel confident to do that. There's obviously the capacity versus demand issue that I've mentioned, you know, as referrals start to increase. Is the funding there? Is the capacity there within the voluntary sector to cope with that? At the moment, we have no consistent mapping system. So there isn't somewhere you can go to just look at and think, I want to find a provider of social prescribing services to do with arts in Newcastle or whatever. There are a number of different projects in different parts of our region and across the whole country that are trialing different types of mapping systems. So that might be something that we can potentially that might happen in the future. However, there's always resources required to do that. So it's very much about more local level relationships. So it's that relationship between the provider organisation and the link workers and the host organisations in order to make sure that there's some visibility there of those services. So that's really important, as is making sure you can promote your offer in the right way if you're a provider organisation. And as I said, you know, there's a challenge around getting the voluntary sector to be ready for collaboration and co-production and commissioning, and the way that that is heading in the future, because it might not be something that people are used to. They're more used to kind of, you know, putting in a bid for their organisation only. But I do think that the voluntary sector is really good at partnership, and I do think that that's a real opportunity moving forward. In terms of challenges for link workers and for host organisations, some of them are the same as those I've just mentioned for the provider organisations, but mainly it's this kind of, you know, diverse sector with hundreds of small specialist organisations working with different communities of interest. So it's very difficult for them to get to know who everyone is and what they're doing. So that's why it's really important for provider organisations to advertise what they do really well and clearly. They're often working with quite large caseloads, which can sometimes lead to high staff turnover. I mean, that there's a lot of work going on nationally, and the National Academy for Social Prescribing are involved in that as well, around support and training and kind of how we train link workers to make sure that they're all at the same sort of level, so that they are not feeling like there's any kind of knowledge gaps or anything like that. So it's kind of around the workforce training element. They obviously want to try and match patients' needs to particular activities around that sort of what matters to them agenda. But as I've said previously, sometimes they might find that, you know, what comes to them as a possible option, there isn't really a service in that area for that person. And that can be because of geography. You know, we've got a very large area with Northeast, North Cumbria and Yorkshire, and a real mix of kind of cities, you know, other smaller urban areas, rural areas, and some quite remote areas. So being able to kind of find those services locally can be a challenge as well. And as I mentioned, sort of the support and supervision systems, which is kind of more related to the how the workforce are actually looked after, how the link workers are supported. You know, that needs to be a really strong system where they get that support both in the clinical side, but also the kind of the supervision side, to make sure that they're not taking on too much of the stresses and the strains of the people that they're supporting, because they have to preserve their own mental health and make sure that they're able to deal with their workload. Again, I'm referring to the mapping system, and not having a consistent mapping system also means that link workers might struggle to identify social prescribing activity in particular locations. And I think the speed of change in the voluntary sector can be a barrier, because of the short-term nature of funding in terms of the delivery of services. it often means that, services can often, funding ends, they can close overnight because they haven't managed to secure any continuation funding. And therefore that can be an issue. But I think overall, if we can try and work more closely together, we can get past some of these challenges by connecting people on a more local level to each other, providers and link workers. And hopefully, as I say, some of the work that's happening in the ICS will actually start to hopefully address this by bringing us together and working more collaboratively. I won't dwell on this slide. This is just a slide that tells you a little bit more about the National Academy. And basically, it's about progressing and advancing social prescribing and working with the partners at a national, at a local level, and championing the work that local communities do to improve people's well-being. The Thriving Communities Regional Lead role, as I said, is a contract that VON holds, and we are one of 7 regional organisations that is providing this flexible programme of learning and development activities. So these sessions are part of that programme. And although we were originally, Thriving Communities was originally about supporting the voluntary sector, so voluntary, community, faith, social enterprise groups, we opened up the network last year to involve social prescribing staff, so any of the personalised care roles, host organisation leads, local authority, public health, basically anyone who has an interest in social prescribing is welcome to join our Thriving Communities network. And obviously the greater diversity we have, the better we can hopefully connect people up across the region to help with those more local conversations. And those are just some kind of headings about the types of activities that we deliver as part of our Thriving Communities programme. I wanted to say thank you for listening. I'm going to stop in a minute, and we've got 15 minutes left, so I can definitely have a look at some questions. Because I've been presenting to a screen, I haven't been able to look at the chat, but I can see that there's a couple of comments in the chat for me to look at in a second. I wanted to highlight a number of networks that VON facilitates. So the Thriving Communities Network is obviously the one that we deliver, connected to the Thriving Communities Network. If you want to join that or any of the other ones listed here, so we have a health and wellbeing network, the partnership programme, which I already mentioned, which is about connecting into the integrated care system, and also a healthy communities and social prescribing network. They each cover slightly different footprints, so do double check that before you apply. So if you're a Yorkshire person, the only one of those that you can join really is the Thriving Communities Network, but all of those networks you can access by following the blue link at the bottom of the page, which you will have when you get the slide deck after this event. But if you are from the Yorkshire area and you want to connect into your own partnership programme equivalent, then we have these contacts here who will be really useful for you. So we have someone in Humber, North Yorkshire, West Yorkshire and South Yorkshire who are all leading on the same sort of programme where they're supporting the voluntary sector, bringing them together as a network, and then helping them to connect into the integrated care system, to understand what's happening, to feed in around their capacity and particular communities of interest that they work with, and hopefully then kind of work together and collaborate in terms of future commissioning. Also, I just had a sort of a bit on the bottom of here which just says if you're a link worker or you are employed by a host organisation, then there's also support available for you from contacts that are there, David Cowan and Kate Pearce, who support the personalised care workforce across the Northeast, North Cumbria and Yorkshire. So hopefully there's a little bit of something there for everybody in terms of what networks might be useful to them, what contacts could be a good contact for them. And I'm going to stop sharing my screen now, and then I am going to just see what was in the chat and see if there's any questions that anybody would like answering. But what I'm going to do is, before we do that, I'm just going to stop the recording. So thank you very much for listening. I'm stopping the recording now.